Welcome, everyone. It's a great pleasure to have this very, very special webinar today with the title, Challenges in Ensuring Equity in the Study and Treatment of ME/CFS and Long Covid. And we're very, very privileged to have Dr. Peter Rowe from Hopkins, Dr. Camille Broussard from Hopkins, and Jailyn Mercadel, who's a nurse, but also will share with us today her lived experience. Really delighted to have this webinar today. Carmen, if you'd like just to kick us off with some housekeeping notes.
You bet. Thanks, everyone. Just want to let you know that you're muted. You may use the question box to send us your questions. You'll see the question box at the bottom of the screen. You can just enter a question there during the webinar. Our presenters will see it, and we'll take as many questions as time permits. For those of you who would like to watch it again or share with a friend, all of our webinars are recorded and made available a few days after the initial broadcast on our respective websites. And you can find all of our webinars on YouTube at www.youtube.com/solveme. And one last note, SolveME is unable to provide medical or legal advice during these webinars, so please keep that in mind when you're submitting your questions. And I'll turn the mic back over to our President and CEO, Oved Amte.
Great. Well, thank you. And this is a very, very special webinar that we're going to have today. And I'm frankly very, very excited to listen to Dr. Rowe, Dr. Broussard, and to Jailyn. And they're going to do something that's very, very unique. They're going to let us into an interaction that happens very often among healthcare providers when they discuss a case. And in this particular case, the person who is at the center of the case is with us. That's Jailyn. And then they will take that case and really help us to zoom out from looking at an individual person and really think about what that means in a broader sense. So it's an exercise that's not often done, certainly not often done in public. So I'm delighted that we're able to do that. And of course, we have the honor of having Peter Rowe with us today. Dr. Rowe is a senior member of the community. He's on the SOLVES Research Advisory Council. But more importantly, he's the director of the Chronic Fatigue Clinic at Hopkins Children's Center, and really has been following and treating and providing care for children and adolescents who live with ME/CFS, with POTS, Ehlers-Danlos syndrome, and others. So really delighted to have you with us today. And then Dr. Camille Broussard is working with Dr. Rowe. She's an assistant professor in the Division of Adolescent and Young Adult Medicine at Hopkins. And she has really taken interest in ME/CFS and really is focused on the research aspect of that, in addition to caring for individuals. And she really has been very involved in issues of equity, diversity, and inclusion. And of course, that's part of our discussion today. So delighted to have you with us, Dr. Broussard. And then it's really a special privilege for us to have you with us today, Jailyn. Jailyn Mercadel is at the center of the discussion today. So thank you for sharing your personal and an important story. But Jailyn is not only a patient; she's also a caregiver. She's a registered nurse. So she really does bring this unique perspective of seeing both sides, and I think that's going to be an important aspect of our discussion today. So without further ado, please, Dr. Rowe, take it away. We're excited to listen to all of you today.
Very good. Well, thank you, Ovid. Let's do the next slide. The way we want to do this, as Ovid mentioned, is with a case presentation and some of Jailyn's comments about her experiences maneuvering through the healthcare system to a diagnosis and treatment. And then the bulk of the discussion is really going to be from my colleague, Dr. Broussard, who I think you'll see very soon why we're so excited to have her join us in this effort at Hopkins. She's going to talk about the epidemiology of ME/CFS and long COVID by race, ethnicity, and income. and then look at some of the disparities that we see in the care continuum, and then suggest some potential solutions to improve equity as we move through the process of treating those who have pre-pandemic ME/CFS and post-pandemic ME/CFS, or long COVID, as many people call it. Next slide. So we'll start with some of the comments that Jailyn made to us when we did our first telemedicine visit with her. She said that she'd been kind of unathletic as a child with poor depth perception, but was quite flexible and could do a lot of tricks. So she could put her legs behind her head, and when she was lying prone, her feet would go past her head. She developed some tachycardia as an adolescent, evaluated by a cardiologist, but really wasn't given any specific advice or follow-up. She was working as a nurse and developed some seasonal allergies. She had some seasonal allergies, but at 22, she started some allergy shots or immunotherapy. But each time she got the shots, she would get a lot of itching and congestion and enough throat closing that she needed a 5 to 7 day course of steroids. And every time she increased the dose of immunotherapy, this would occur. So by the 18-month point of building up the immunotherapy dosing, she was only at a half of the full dosage. Next slide. So she was working full-time as a bone marrow transplant nurse, very high intensity unit at Emory at the onset of her main symptoms in March of 2019 at the age of 23. We couldn't identify specific clear triggers to the onset of symptoms. She had had a car accident 3 months before, but didn't lose consciousness and wasn't really requiring any specific treatment for that. She had started rock climbing in the preceding year, which may prove to have been important, but started really progressing with the frequency and severity of her symptoms over the next 18 months. And she would get a big exacerbation in symptoms every 1 or 2 months, lasting almost half the month. She'd been referred to multiple subspecialists by her primary care provider, but she got to the point where she was unable to continue working by July of 2020. Next slide. So these were her symptoms. She was fatigued. These are things that everybody with ME/CFS will acknowledge as common, but she would get worse after any activity. So she could work 2 of her nursing shifts, but then would need 2 days to recover. So evidence of post-exertional malaise. She had headaches that were at an 8 out of 10 severity. She had neck pain, lightheadedness, brain fog, lots of aches and pains. She couldn't hold her arms overhead, and she avoided things like washing her hair, had to do that in brief spurts. She had itching and facial flushing and a lot of other symptoms, night sweats, some right-sided numbness and tingling, an unusual new sense that sensory things were overstimulating her, and she had, for the first time, some panic symptoms. Next slide. So, Jailyn, maybe you could talk here about how you were treated in the medical system for these symptoms.
Right. So, hello, everyone. To begin, really, I started with fatigue, the night sweats, weight loss. As normal people do, I made an appointment with my primary care. She ran lab work, assessed me. Things were normal from her case, besides all these symptoms. So she said, let's send you to endocrinology. It sounds like it may be a thyroid issue. You have a history of thyroid cyst. The endocrinologist worked me up fully. Some of the tests did come back abnormal, but there was nothing that she felt she could give me a full diagnosis for to explain the multitude of systemic symptoms. So really that ended up being the story of my life for the next couple of months, multiple months. Pretty much every month I was presenting a new symptom and was being referred to different specialists because of that, and referring myself to different specialists, neuro-ophthalmology, dermatology, cardiology, rheumatology, the list goes on. And the same thing was happening. Some of the tests were coming back abnormal, but there was nothing that they felt like they could diagnose me with that explained everything. So really at about the six-month mark from my initial symptom presentation, I ended up having a sudden stroke-like event at work. When I got to the ER, my initial stroke assessment was abnormal in the sense of my speech. I had a right arm drift, I had right-sided numbness and weakness, but my head CT was normal. So I ended up seeing the neurologist about 7 hours after I presented to the ER. And she informed me based off of everything they looked at that I was having a panic attack. I pushed on that a little bit because I said I didn't know a panic attack that lasted 8 to 9 hours. So could she run further testing? Would that be possible? She said she felt there was no concern at this moment for that, and that the symptoms would eventually resolve. We pushed a little bit further and she did agree to do an outpatient neurology referral. At that neurology appointment, I had pushed to have a brain MRI and cervical MRI done before that appointment based on the symptoms I was presenting with. The neurologist informed me that though that imaging was clear, and my physical neurological assessment at that moment was abnormal in multiple areas. So he said based on those things, he was diagnosing me with conversion disorder. And for some of you who may not know, conversion disorder is a condition where, simply put, your brain can manifest physical symptoms based on an underlying mental health condition, whether that be an anxiety disorder, personality disorder, whatever that may be. So for the next 6 months, I was spent in psychiatry, and while also still referring myself to multiple other specialists, because in my gut, I just felt like something else was going on. And the psychiatrist agreed. They said that I did not have conversion disorder and actually sent recommendations back to the specialists who had not worked me up, so neurology, rheumatology, and asked that I be further tested. And at that point, I kind of became blacklisted as a patient because providers refused to see me again. So they would see my history of the conversion disorder diagnosis and all these symptoms, and just refused to see me. So at that point, I was desperate. You know, I had been barely working, really low quality of life. So I made a decision to go to an out-of-state clinic that had a national diagnostic program, and they diagnosed me with POTS, which was fantastic because that was one of the things I guessed I had at that point. But they still couldn't, you know, explain some of the other symptoms I was having, especially the neurological piece at that point. So I was actually put into contact with Dr. Rowe, and really from that first appointment, my life changed at that point, and the rest was history.
All right. So how did Jailyn get in to see us? Well, her mother worked for one of the people who had been at one point the interim head of the CDC, but his most amazing claim to fame that he was an intern when I was the chief resident in pediatrics at Johns Hopkins. And he called me up and said, hey, you know, my executive assistant has a daughter who really needs your help. So we arranged a telemedicine interview with Jailyn and her mom. And that group of symptoms you saw in the earlier slide was really quite extensive. But the thing that jumped out to us was that she was describing neck pain. This was daily. It was worse with bending her neck forward to flex it. She had found a neck traction device at home, and that had helped with improving the symptoms. And then when she turned her head to the side, she would feel this crunching, crepitus sound in the neck, and said very importantly to us that her head and neck felt unsupported. So in the next slide shows you what we thought was going on here. First, her flexibility as a young child was consistent with hypermobile Ehlers-Danlos syndrome. And we know that that's overrepresented among people with ME/CFS, and it's a risk factor for developing orthostatic intolerance syndromes. We see hypermobility in 60% of the adolescents we see with ME/CFS versus just about 20% of the healthy people. She had some of the other things that go along with that: irritable bowel syndrome, some seasonal allergies, The extreme reactions she was having to immunotherapy suggested mast cell activation, which is more common in those with Ehlers-Danlos syndrome. The difficulty with arms overhead postures suggested a neurogenic thoracic outlet syndrome. She had some TMJ pain that suggested dysfunction. That's also more common in Ehlers-Danlos syndrome. But the neck symptoms and the fact that her head felt heavy and unsupported was consistent with something that we're recognizing more and more all the time: craniocervical or atlantoaxial instability. This is ligamentous instability at the top of the spine and the skull base. And she had developed some anxiety. So what we did was we thought, well, keep going with your local physicians trying medications for the POTS. We sent her to a different allergist for a mast cell activation syndrome evaluation. And then we asked Jalyn to send up the MRI that had been done and called normal. We suspected it was going to be abnormal, but we also put her in a hard cervical collar, shown on the right. This is to immobilize her neck so that if there's a lot of ligamentous movement, this would reduce the movement and the bashing micro trauma of the cervical spinal cord. And then we scheduled an in-person visit. So with the hard collar, she had an immediate resolution of her headaches and her neck pain, much more energy. She was able to do consecutive hours of activities and trips out to the store. Fairly substantial improvement in the lightheadedness. People noticed that her speech was more fluent, and some of these sensory symptoms got better. She had fewer night sweats. And then as she came up to see us, she thought we had wanted her to take the collar off, which was not part of our plan, but it worked out beautifully because as soon as she took the collar off, all of these symptoms returned. So we really had a lot of diagnostic information from just the period of time in the cervical collar. So when we examined Jalyn, as you can see, she's alert, she was composed, she had a high Beighton score indicating the joint hypermobility, and she had a number of other features you see with Ehlers-Danlos syndrome, including the pisogenic papules or pressure papules of the heels in the upper right. The other thing that was amazing is that how anyone could have regarded her physical examination as normal is astonishing. Her deep tendon reflexes were quite brisk and pathological. We could elicit a deep tendon reflex tapping her 10 centimeters above the patella. Her Hoffman sign was abnormal bilaterally. That's a sign that indicates some irritability of the nervous system, usually in the cervical spine. She didn't have a gag reflex. That's a reflex that disappears if you've got problems like Chiari malformation or cervical spinal cord problems. Again, an objective finding that nobody should have missed. She also had some reductions in sensation on the right side of her face, and then the neurogenic thoracic outlet syndrome was elicited with this test where you have your arms overhead for a minute or two. We then went on because plain MRI imaging often misses instability in the ligaments. So you need dynamic imaging where the CT scan, as you see in the bottom right, was done with flexion, extension, and then lateral rotation. And with that, she had 5 millimeters of movement in the front back direction at the skull base. Normally, you should have less than 1 millimeter. So this was objective evidence of craniocervical instability. And then with the rotational movements, she had 43 degrees of rotation of C1 on C2, the top two cervical vertebrae, and 45 degrees to the left. And many people think that if you go beyond 38 degrees, this is abnormal and can lead to pinching off of vessels that supply blood flow to the brain, as well as twisting in the cervical spinal cord. So she underwent an occiput to C2 surgical fusion in March of 2021. Her headache and neck pain resolved. Her head now feels quite well supported. She's had gradual improvements in energy, tolerance of activity, and unfortunately for her mother, shopping. She's no longer lightheaded. She has had improvement in this whole myriad of symptoms that were confusing initially. She feels sharper. She's been able to work part-time, increasing that volume gradually. We haven't cured her EDS, obviously, so she still has a number of other health problems, but overall, her sense of well-being improved from about a 30 before surgery to 80 now. So Jalyn, you had a few other thoughts about how things went.
Yeah, so actually when we were still in one of the in-clinic appointments with Dr. Rowe, we ended up discussing I see a lack of Black patients, just in my support groups, going to appointments, just hearing about it. And, we discussed that further with him. And actually, my mom and I ended up discussing it even more on our plane ride home. And just, when you look overall at the communities of color and equities in healthcare, you think about lack of access, systemic racism within the system, things of that nature. But when we looked at me personally, I was very fortunate, very privileged enough that a lot of the barriers didn't exist, and I still ran into the issues. So I had access to insurance. I had a knowledge of the healthcare system, which ended up benefiting me greatly. Things like I had a weekend job schedule, so I was able to do appointments during the week, testing during the week. And I think a lot of those things ended up saving me diagnosis time. When we thought about it within my community itself, and when I think of Black culture, I can't speak for every Black person, right? But at least within growing up, my friends, family, community, healthcare is viewed as something that nobody has time for. And really, that's just a general sense of, my mom used to say to me all the time, if you're not dead or bleeding, don't worry about it. Like, I don't want to hear about it, And it's just, if you're able to function day to day and it's not serious, you usually aren't putting yourself in a system that generally most people like me don't feel safe in. And, that comes from historically a sense of mistrust. There are stories still run now in the community of patients being gaslit, of being misdiagnosed. My case, for example. So generally in the community, there's not a run to, I'm feeling really, really tired. I'm sleeping a lot. You're sleeping, but we have things to do. You have kids, you have work, that's just, the concept of things. Again, when I thought about it personally, I think the biggest barrier I ended up running into was a lack of education, and really in multiple areas. One being just a lack of education that the providers didn't know that these conditions even existed. When I presented research to them, they, saw it, but even from then, about it superficially, but they don't know the symptom presentation, the treatment, what specialists to even send patients to. And also that these conditions could exist in other ethnicities or races. So before my diagnosis, I was told by a geneticist that Black people cannot have EDS. It didn't exist. And after my diagnosis, still to this day, I see providers and they tell me, I've never seen a Black patient with EDS or chronic fatigue, stuff like that. And then also the last piece, which I actually think gets overlooked a bit, is lack of education within the community. The first people to hear about if you start feeling sick or start having symptoms are your friends, your family, church members, people you're talking to at the hair, wherever it may be. And still personally to this day, I don't know anyone within my community with my conditions. So when you're talking to people and you're explaining, how are you doing? And you're saying all this stuff, there's no one to say back to you, oh, I had a cousin, Sarah, and she had some of that same stuff. Have you heard of something called chronic fatigue syndrome or POTS? That didn't exist. So I think when putting all those things together, those were kind of some of the concepts and reflections that we had.
Yeah, Jalyn even put all those together into a fairly lengthy email that was really helpful for my understanding of things. And at the end of it, she put, "That's the end of my TED Talk." Okay, what's the next one, Camille?
All right. So thank you so much, Jailyn, for that wonderful discussion. So we're going to now take the really cool step back and move on from one particular case and look at the bigger picture of health equity within sort of ME/CFS and long COVID. So we're going to first talk about the community-based epidemiology studies of ME/CFS first. So the first one that was published was in 1998, and this is by Steele and colleagues. And it was actually an epidemiology study of chronic fatigue in general, and it was in San Francisco at the time. This was only done in adults, and they used basically a random digit telephone dialing system with a detailed telephone interview. And at the end, sort of this is the table 2 that they describe in the article that talks about, I've highlighted here, that in the case of this CFS-like category, so they tried to make the diagnosis of CFS based on the 1994 Fukuda criteria. Basically, what they're saying is that there is a higher prevalence or higher number of people in the Black and Native American community that have this CFS-like picture. They also actually looked at household income, and they broke it down into sort of less than or equal to $40,000, annually, or those that have greater than $40,000. And basically what they saw is that if you had more than $40,000 of household income, you had a lower likelihood of actually having the CFS-like illness on telephone interview. And so that was actually followed up by Jason and colleagues in 1999, where they, instead of just looking at chronic fatigue, they expanded this and made sure that they looked at chronic fatigue syndrome specifically. This is another community-based study out of Chicago. And so what they looked at here, as you can see, is a very similar picture to the previous slide. So in this one, they're looking at the prevalence rate of having CFS after, multiple interviews and then an in-person exam. And what they were looking at is that actually, if you see the Latino population has a higher prevalence rate, so they have higher numbers than expected in terms of the CFS diagnosis. And then when it comes to sort of white and Black populations, it's about an equal sort of prevalence rate. And then the next one we have is out of 2003, and this is by Reyes and colleagues. This was actually done in Wichita, Kansas. This is another telephone-based, community-based study. And what they did a little bit different in terms of race categorization here. They did sort of white versus non-white, but as you can see, basically, when looking at this CFS-like illness, they're showing essentially almost equivalent prevalence per 100,000 people. They also then split actually up the race by gender as well. And so if you kind of look at this, you still see this sort of female predominance in terms of CFS illness, but then there's a slightly higher prevalence in terms of non-white females versus white females on this study. They also looked at household income, just like the first study that I mentioned. And essentially what this is showing is across all incomes, no matter what sort of the income is, you have basically equal prevalence rates of CFS. And then we also actually have seen a very similar situation in the pediatric population. So Jason and colleagues did a very similar study, but just in pediatrics this time. So this was 5 to 17-year-olds, still in Chicago. And what you see essentially is Black populations and Latinx populations continue to show this higher prevalence rate. So those populations are having higher numbers of ME/CFS than white populations. So then now let's actually look at, well, what are we actually seeing in our clinic-based studies that are reporting on ME/CFS? So this one is this is actually the multi-site clinical assessment of ME/CFS. So this is actually a multi-site rolling cohort study that was done in 2012 in terms of from 7 clinical sites. It's by Unger and colleagues. And what you can see actually from this is you see a very different scenario than what we just had seen on the community-based studies. So an overwhelming almost 95% of their populations in clinic were actually white. Very few Black population, and then very few from sort of like an all other group. And then when you also actually look at the breakdown by educational level, this is also a highly educated group where more than actually 3/4 of the population have at least a college level, and a whopping 37% actually have more than a college education. So predominantly a white population, predominantly affluent, and predominantly highly educated. And we see actually a very similar rates in our pediatric clinics. So this is actually from the Hopkins pediatric cohort study back in 2008 to 2014. This was just 55 patients, but overwhelmingly, the percentage is 94% that were white. There were 4% Native American and 2% that identified as Asian or Pacific Islander. And while it's not quoted in the study necessarily, this is a mostly affluent and educated population that is being seen in the clinic. And then, we've been talking more about sort of US-based population studies, but we even see the same sort of trend in our subspecialty clinics elsewhere outside of the US. So this is actually from Kathy Rowe's clinic in Melbourne, Australia. And interestingly, if you read the discussion section of this paper, what you see is this very interesting commentary where it says, actually, when you look at the rural urban mix of the demographics of the clinic population, it's actually proportionate, which means it's actually, representative of the population of Victoria. However, she mentions that the ethnic mix was not representative of the population of the state or of even the clientele of the hospital. And so it says that, despite Victoria having successive immigration waves from over 200 countries, so very, very diverse, 80% of their CFS patients have this Anglo-Celtic background, which currently sort of approximately represent 25% of the general population. But even if you look at that population, it's predominantly this Scottish Irish descent and another 11% of Northern European descent, which were Dutch and Scandinavia, which even represent an even smaller proportion of the general population at less than 0.5%. And then she lastly noted that Middle Eastern, African, and young people of Asian descent were significantly underrepresented. And this was another pediatric clinic-based study. So now what are we looking at when we're talking about the epidemiology of COVID-19 and long COVID? Do we see something similar? So this is CDC information, and this was last updated in the beginning of November. But and then there was a JAMA article that talks about sort of looking at all the data that has been published on risk for COVID-19 infection, hospitalization, and death by race and ethnicity. And what you can see is compared to white non-Hispanic populations, our Native American, Alaska Native, our Black, and our Latino populations in the US have a higher likelihood of having COVID-19 infection, but also hospitalization and death. And only really the Asian non-Hispanic population has a lower prevalence of than even compared to our white non-Hispanic population in the US. And then when you look at long COVID, this actually comes from the National Center for Health Statistics. This is the percentage of adults who have ever had long COVID by race and ethnicity. And this is as of sort of the summer. This was asking for self-reporting of long COVID symptoms. And this is sort of reflective of any symptoms of COVID that last 3 months or longer, sort of met this definition. And what you can see is the Hispanic or Latino population has the highest sort of percent of adults who have ever had long COVID. And then that's followed actually by other races and multiple races. And then if you look at sort of white versus Black, it's pretty much almost equivalent in terms of percent. And then our Asian population has a slightly lower percent of adults who have ever had long COVID. And so I was really curious, when I'm looking at all of these data and all of these studies and all these articles, what is actually being written about this in the media and what is being presented to patients. So this is actually a smattering of what has been in the news. So we have like an example of an article, and this was all sort of this summer coming out. The Guardian has this title that says long COVID is said to affect, white middle-aged women more, but data suggests otherwise. So they're kind of talking about race, wealth, and free time dictate who gets to be treated for long COVID, making the condition the new pandemic. And I believe it was in this article that it was talking about long COVID treatment has now become a luxury in the US and a sign of more privilege and wealth. And then there was this interesting article in NBC News that talked about Black COVID long haulers are feeling invisible to the healthcare system. And so they formed their own support groups. And so it was really interesting article about how these Facebook groups are popping up for people who identify as Black and identify as having long COVID to support each other in their quest for getting treatment or finding treatments at work. There was also in September, at end of September, there was a New York Times article that talked about where all the post-COVID patients, and this article describes sort of, we saw the numbers of how many Black and Latino populations, or people, I'm sorry, that were affected by COVID infection, that the assumption would be that that would then lead to this higher proportion of Black and Latinx patients in our like post-COVID or our long COVID clinics, but that is really not what is happening. We're seeing more of the white population in our long COVID clinics. There was one article that stood out though, just a couple days ago, or just a couple weeks ago, actually, that actually was different than all the other articles, that talks about being long COVID symptoms are most common among Latinos and residents of the Bronx. And so this was actually new data from the New York City Health Department that talked about disparities in access to care. And then we even have an article out of Time back in 2021 that talked about Black women are fighting to be recognized as long COVID patients. And describing the advocacy and the help that is going on with allies from this ME/CFS community. So we really have this prevalence discrepancy dilemma, right? We have our community-based studies that are saying that, for the majority of ME/CFS, when you look at the studies, right, there are either a higher prevalence or an equivalent prevalence of racial and ethnic minorities being diagnosed or having ME/CFS. But we have the opposite sort of actually happening in our clinics, where we're seeing more white populations in our clinics. So what to think about this discrepancy, right? There's two answers. Despite the community-based studies being very rigorous and being and using the 1994 Fukuda criteria, potentially are these capturing chronic fatigue related to either social determinants of health or other sort of potential causes that is mimicking ME/CFS, and thus the prevalence of ME/CFS is truly higher in affluent white populations? Or is it the case that there's actually an equity gap or disparities, so that community-based studies actually do represent an accurate prevalence rate, which, like I mentioned, is equal or greater prevalence in racial and ethnic minorities? Thus, our clinic-based samples are actually the ones that have an overrepresentation of affluent white populations. And in our view, we think that this is probably the more likely scenario, and that's what we're going to focus the rest of the discussion on. So I actually really like this. This comes from this care continuum, actually comes from the HIV care continuum literature. And it basically talks about where in someone's care can you actually end up having disparities in terms of outcomes or access. So I took that model from the HIV care continuum and actually applied it to our ME/CFS care continuum. So I see this as where can disparities occur. So it can absolutely occur at the recognition of symptoms by either the patient or the primary provider. It can also occur at diagnosis. So maybe somebody recognizes the symptoms by the patient or as a patient or as like their primary care provider, just like, Jalen's PCP was heavily invested in her care, but then getting the actual diagnosis, there can be a disparity, right? Because of a lack of knowledge and other things we'll talk about. But then finally, when you get the diagnosis, there can be a disparity even getting linked into care. So it's not enough for someone in the Black or Latinx community to have the diagnosis, but how do we actually get linkage to care and treatment? And then finally, also, how do we, once we get linked into care, actually get our populations to be retained in care when there's so much going on, leading to disparities, unfortunately, anywhere along this care continuum, and improvement in function and well-being. And so when I think about this and thinking about the problem that clinic samples are likely not representative, I think of disparities in access to care as being probably one of the #1 challenges. And I think of this as being sort of systemic barriers, group disadvantage for racial and ethnic minority groups, as well as those that are low income, as well as systemic racism that we know exists in the healthcare system. And that includes everything from navigating complex health systems, which Jailyn mentioned. She was a nurse, and so she kind of knew already how to navigate complex health systems. But if you are from a historically disadvantaged group, you may not know exactly how to navigate these complex health systems and get to the subspecialist that you need. There's also this concept of social capital to gain priority access. So, knowing one of our providers personally may be able to get you priority access to be able to be seen in clinic. Dr. Rowe mentioned how Jailyn was able to kind of come into Hopkins clinic because we knew someone in her social circle. But if you think about it, historically, Black and Latinx populations, as well as Native American populations, have lower social capital on the whole when you think about this. And so having lower social capital may put you at a disadvantage in terms of gaining priority access. There's also, as we know, a lack of clinics nationally, and especially in communities serving low income or racial and ethnic minority groups. And then there's also this huge stigma associated with chronic illness and fatigue among low income or racial and ethnic minority groups due to long-standing stereotypes. So there's absolutely a stereotype that Black people are lazy. And so if you are kind of thinking about this as a person and saying, wow, I have a lot of fatigue, and if I bring this, up to my parents or my community members or my doctor, am I just going to look like a lazy person and that I'm not trying my hardest, to get out the door and function in society? And so that stigma and those stereotypes play hand in hand together in terms of being able to even access that care. And then there's this intersection of medical gaslighting, gender, and bias against racial and ethnic minorities. So we know that implicit bias exists in our healthcare system against racial and ethnic minorities, but add that on top of what we already know about medical gaslighting in the ME/CFS community, about how people tell our patients that this is all in their head. So if you compound that, that's what intersectionality means, is that you're adding all of these disadvantages on top of each other. There's also a well-known problem that Black women in healthcare are not believed when we report our symptoms. And so that's another big issue in terms of access to care. There's also, as Jailyn talked about, earned mistrust in the healthcare system among racial and ethnic minority groups, where there's been a lot of historically unethical problems that have happened, whether that be in care or research, to make people not want to access care and not go to care unless, like Jailyn said, you're dying. There's also a lack of culturally responsive care. And then if we look at, nationwide, unfortunately, our racial and ethnic minority groups tend to be underinsured or uninsured, and that can obviously impact access to care. But then I also think about this as lack of recognition of ME/CFS in racial and ethnic minority groups. And Jailyn hit on this as well, but it can be by providers, by patients, and then also this idea that there is a misdiagnosis. So being misdiagnosed as having depression or anxiety or conversion disorder, as in Jailyn's case, or, like she was told, EDS cannot present in a Black person. That's just wrong, right? And so that lack of recognition continues to further this disparity. But then also we have to recognize that ME/CFS or long COVID, getting those diagnoses and then finally receiving treatment is super resource intensive. It requires time, it requires tangible and intangible resources, as well as money. And if you think about it, you need a job that has flexibility so that you can actually attend appointments. Most of our providers, we don't work on the weekends. We don't have super late hours when people are off of work. And so you have to have a job that has that flexibility. You have to also have that job that has actual healthcare benefits for you to actually to be able to get access to care. So if you think about that as the whole, if you are a frontline worker as a Black or Latinx patient, you may not have all of the resources that someone else in a higher paying job might have. And so this is really my call to action for all of us, is that I think that we've talked a lot and I've described all the studies that have been done since the early 90s or mid 90s, but it's not enough really for us to just describe these disparities in diagnosis and treatment. And it's not enough to have more articles, in all of these outlets, but we really need to take action now. We've got to do something about it. And so when I think about sort of potential solutions to increase equitable care, I think of sort of these three pillars of like medical education is much needed. So we need to make sure when we're providing provider education materials that this actually includes information specifically that this is a chronic illness that affects all. So this affects all income levels, it affects all racial and ethnic minority groups. Because I think if we're not explicit about this, the sort of perpetuity of this only affects white patient populations will continue to go throughout the provider education material and in providers' minds. We also, which is a huge issue in healthcare, need more diversity in the images shown when we're teaching. You know, we will admit today, right, our images of the cervical collar as well as the heels picture were not representative of who, right, Jailyn is in terms of when she presented to clinic. And so if we only have a sort of images of like the Beighton score in being white populations, then our brain makes those automatic associations naturally, right? Because that's important for pattern recognition. It makes those really quick synapses to make sure that you understand that pattern. So if we don't see more diverse images, we'll never make that connection that this can happen in Black and Latinx populations. And then also we need to really continue our CFS and Long COVID echoes, which those are, for you that are not familiar with that acronym, it is a sort of telementoring educational output where providers that are experts actually provide webinars and teaching for other providers to make sure that they understand diagnosis and treatment, and making sure that those echoes actually incorporate the equity lens that we're talking about today. And then we really need to meet our patients where they're at. So that's making sure that our clinics and clinic outreach are in communities that serve racial and ethnic minority groups, but it's also like spreading awareness through culturally relevant outlets. You know, Jailyn mentioned that nobody in her circle, you know, even at church, knows about this, right? So making sure that churches, barbershops, hair salons, also news outlets that serve very diverse groups, The Root, Telemundo, anything like that, where you have sort of more awareness in different groups can help. And then also looking to increase our workforce diversity and inclusion. So I will say, you know, I identify as a Black woman. And since joining the clinic here at Hopkins, I have seen more residents reach out to me and ask about certain patient population, like, hey, should I refer this patient to your clinic? And just having, you know, someone that looks like them either as a resident or as a patient can also help sort of making sure that we're making care equitable. And then we have to reassess our referral pipelines. You know, I know that a lot of our clinics have very, very long wait lists, but we need to provide education to clinics serving various populations that are associated with your maybe primary clinic. We've also got to be very intentional to outreach to diversify our referral pipelines. And that can look like thinking about partnering with community organizations as well as schools for those that are in pediatric care like we are. And then we have to make sure that because we have waiting lists, that our waiting lists are equitable and fair, and making sure, you know, that we're considering, you know, how are we constructing our waiting list and how are we taking, you know, how are we prioritizing those lists? And then I'll give you an example quickly from the Bronx. So the New York City is tracking sort of long COVID by race. And what they're showing is that, in fact, yes, the Latino or Hispanic population, looks like a 30% prevalence rate for long COVID of just having one symptom after an infection. And then they talk about this COVID-19 recovery clinic at Montefiore that's located in the Bronx. And it says, you know, this New York Times article says, like, at this clinic in the Bronx, the population of the clinic actually reflects the diversity of the surrounding community, so that a half of the patients are Hispanic, a quarter are Black, and 15% are white. And thanks to doctors who are familiar with the challenges of navigating Medicaid, these patients receive referrals to physical therapy as well as subspecialists that they're able to access. So it really takes this culturally sensitive and culturally knowledgeable care to the next level. So it can be done. And then I just want to leave with that we can't just do this in care, we've got to do this in research as well. And so we've got to work towards including racial and ethnic minority and low income patient populations in diagnosis and treatment studies on both ME, CFS, and long COVID. We've also got to meaningfully engage our community advisory boards and studies. And then we've got to consider our recruitment methods and how to make sure that we're ensuring a diverse sample. So that's it looks like intentional outreach and recruitment, understanding that there is a history of unethical practices that has happened in research. And so we have to overcome that and make sure we're making connections genuine and authentic. And I'll leave you with this example that our clinic is trying to partner with our Johns Hopkins community physicians. And that's actually a bigger group of clinics that represent a huge wide variety of socioeconomic and racial ethnic populations. And we're trying to do an outreach with those community partners to say, hey, this is who we're looking to make sure that we're capturing a very diverse group of patient referrals so that no one's sort of left out without care. And so we just wanted to thank you all for giving us this opportunity to present about a topic that we are also very, very passionate about. We also wanted to thank all the previous grants we've had to be able to do this work, but most of our work is actually funded through philanthropic donations. So Dr. Rowe is actually an endowed chair of the Sunshine Natural Wellbeing Foundation. We'd also like to thank the Boys Family Endowed Fund and Allison Caldwell Endowed Fund. And then we've got amazing colleagues like Colleen Martin, Renee Swope, Rick Veland, and Megan Swope helping us out. We've had a numerous summer students and research assistants. We've got the Rose Research Runners that's helped fund our research. Special thanks to Emily Steffensmeyer. And then we've got, of course, Jailyn and her mother, Mercadel, for sharing their story. And then our many, many families and patients that have allowed us to take care of them.
Wow. Well, thank you so much. And Jalyn, first of all, thank you for sharing your personal story. And I think this was an incredible way to illuminate those issues that we really need to address, and obviously beyond one individual case. But that was a terrific way to help us all understand that. We got a lot of questions, and I'm going to just maybe a few questions that came from the audience. One question that came in, and I think that's kind of interesting. You touched on that, but when we talk about fatigue, about long-term illnesses, different communities, different ethnic groups may understand. I think that's the question, or maybe perceive that differently. What are your thoughts about that? And do you are you concerned that having different understanding of fatigue, for instance, would lead to different outcomes? What are your thoughts, and how do you see that in different groups?
Yeah, I think honestly, it goes back to a lot of the stereotypes I was mentioning, right? And so if there's this historical connotation and stereotype that Black people are lazy in general, if you think about that as a person, if you start to have fatigue and you're not able to get off the couch, you're not able to go to work, you're not showing up as you want to actually show up in life, right? You're not going to want to present to the doctor and report those symptoms, because you also might have had a previous interaction with that healthcare provider about something completely different, say like a viral infection, and they maybe were dismissive with just a simple viral, right? But something as complex as fatigue and what sort of that could be from. You can imagine if you already understand that I don't want to be labeled as being lazy. I just don't. I'm not going to be forthcoming, and I'm not going to kind of bring that up until I'm at the point where, like Jalyn said, I haven't been able to work, right? Where it affects you to the point where now your livelihood is at stake. So I don't necessarily know if there is a difference in terms of the understanding of sort of fatigue from like a cultural perspective, but I think there's a social context to understanding why people think about reporting symptoms differently in different groups. And I think it has a lot to do, especially in my experience, with the way that we see different populations and the way that we categorize different populations. Because if you think about it, race is a social construct. It's not biological. And so we're not looking for, genetic differences. We're talking about what has happened to different populations as a whole socially and how that presents in the healthcare system. Thank you for that question.
Yeah, that's very interesting. And maybe a question, I'm going to ask the same question to both Jailyn and you, Dr. Rowe, but in a different context. So what can we individuals do and to address that and really to go back to our communities and push for more equity? Maybe Jailyn, start with you, and you've had this long experience and you've shared this with us today, which is remarkable. But when you think back of other people who go back to their communities, what can they do as individuals? What are the things that you found to be effective or to help you or help others?
Oh, I can't speak from a scientific background on specifically these are the things that help. I can only talk about in my community specifically. Since I've been diagnosed, really just talking to people. I don't think when people obviously who followed me through this whole journey, never would they have expected, oh, you needed neurosurgery. You were just, you were sleeping a lot, but you ended up needing neurosurgery like that. It just doesn't, those things don't go together for them. So I think just talking to people, saying, even though you think things are simple, it's just fatigue, it's just joint pain, stuff like that, going to get it checked out doesn't hurt because it can save you the extremes that it may get to by, waiting.
Yeah. Thank you. And Dr. Rowe, you're working within the system, and you're privileged to be in an elite institute and in an influential position. What did you take upon yourself to start implementing a change?
Yeah, so I want to step back a bit from that and go back to one of the comments Dr. Broussard made, and I want to just also give her kudos for doing this while she has COVID herself. She has not been into work for the last few days because she's miserable, but she's on the mend. One of the problems with the whole ME/CFS world, and they're seeing it with long COVID as well, is just the complete mismatch between the number of patients who need care and the number of people who are running clinics where there's some capability and experience. And we're one of them. But for about 25 years, I was doing this primarily on my own. It was only 2 years ago that we were able to hire Renee Swope as the clinic nurse, and only 6 months ago that we were able to hire Dr. Broussard, and we're grateful for the contributions that have allowed that. But during the time I was doing this by myself, there was no way to have a waiting list without ruining all hours of every day and every weekend. It was just too much. So the intake was kind of random. It was not intentionally excluding any one group, but I had to, respond when I had free time. So I think one of the things we have to do that's been a glaring problem since the COVID pandemic is get many more clinics funded, supported nationally. And it can't be on the same model as standard clinics where it's fee for service. Patients are too complicated. You won't ever be able to take care of them in 15-minute visits. We've got to have a better way of funding complex care. And I think that will help all races.
That's terrific. Well, we're unfortunately coming to the end of our hour today, and I wish we could go for much longer. But first of all, Jenny, thank you so much for sharing your story with us. I know it takes a lot of, and that must be your mom. So thank you as well for allowing us to get to know you and to learn from your journey. And Dr. Broussard, this has been phenomenal. And Dr. Rowe, we really appreciate you doing that with us today, and we look forward to continue this discussion. And I will just close by a couple of things that Solve us as an organization are taking on next year. The first one is to build a new lived experience task force, and we're looking to have a group of people who will be able to work with us. share their stories, and really help all of us get a better understanding of the complexity of the disease, so that we can go back to our communities and really do a better job. And the second one is also through a generous grant that we received from the Jan Zuckerberg Initiative. We'll be putting together a training program that is intentionally designed to create a more diverse and representative group of patients who could be trained to become advocates for research. We all know that participating in research is incredibly important, but we want to make sure that people are equipped to be there and at the same time advocate for more diversity and inclusion in scientific research. These are some of the things that we're taking on next year. And of course, I encourage our viewers to join us and really apply to any of those possibilities that we're going to be doing next, activities that we're going to be doing next year. So I can't let all of you go before I mention that this is this time of the year. That everything that we do, including this webinar and supporting research like the one that Dr. Broussard is doing, is only possible through your generous contribution and support. So thank you for being such strong supporters of our organization. And this is, I believe, our last webinar for 2022. So I wish all of you happy holidays, and thank you so much for joining us today.
Thank you for having us.